60% of doctors in family medicine, pediatrics, and internal medicine say they are, guess what, burned out.
Studies show more than half of doctors say they've felt burned out. Physicians are also more likely to have depression and have the highest suicide rate of any profession, twice as high as the general population.
The U.S. Surgeon General, Dr. Vivek Murthy, warns that doctors have been pushed past their breaking point due to COVID-19. He says that the pandemic has been a, quote, uniquely traumatic experience for the health workforce and for their families.
The American Medical Association says the U.S. faces a growing shortage of physicians, especially those in primary care fields like internal medicine, mental health, and pediatrics. By 2034, the group predicts a shortfall as much as 48,000 primary care doctors, driven by population and demographic trends and burnout.
Hey everyone, I'm Matthew Handley. Today we are talking about physician burnout, a very important issue that has long-reaching effects in our healthcare system. Our special guest for this conversation is Dr. Damian McHugh. Thanks for joining us. This is the FLATLINING Podcast from Fulcrum Strategies. Joining me right now is Dr. Damian McHugh, who is an emergency medicine physician in Raleigh, North Carolina, and now serves as the managing director, physician liaison for Curi, a full-service advisory firm dedicated to helping physicians in medicine, business, and life. Dr. McHugh, it's good to make your acquaintance.
Good morning, friends. It's good to meet you.
Also with us is Ron Howrigon, our president and CEO of Fulcrum Strategies. Hello, Ron.
Hey, how are you?
So, Dr. McHugh, I want to talk a little bit first with some kind of easy get-to-know-you kind of questions so we can get an idea about what your background is and what got you interested in medicine. So that's really my first question is what got you interested into becoming a physician? What got you interested in medicine?
I'm a simple kid from northern England. Imagine that kind of grimy northern town that's filled with canals and coal. I realized when I was growing up that my sporting prowess was never going to earn me a career, but what I did understand was I was keen on STEM subjects, and I also had a burning passion to just help people. I found that was important in my family and amongst my friends group with injuries in sports, and it's just something that grew on me, and I decided that was the thing that I needed to pursue in order to make a contribution to the world.
And what about emergency medicine in particular? What drew you to working in an ER, working in a high-intensity situation like that?
First of all, it's fun. Secondly, it's deeply rewarding. Many ER docs will be described as adrenaline junkies. I think part of that is fair, but I think also the vast majority of ER docs that I've ever interacted with have been very committed, dedicated individuals who don't mind working nights and weekends and will proudly step in to some of the most challenging and hardest situations in medicine and life, and will try and bring their personality and their skills to help and heal.
Can you tell me about a particularly challenging situation that you faced when you were practicing, when you were in the ER?
Every day is a challenge. There are truly hundreds and hundreds of patient encounters, but every day is a challenge. I mean, imagine just walking in not knowing how you're going to find the department at 701. You may find 3 ambulance patients that have just come in, and within 30 seconds you need to prioritize who gets your attention first. So just that daily challenge of everything being new, everything being fresh, everything being a deep stimulus that tests you constantly. That's really just how emergency medicine is, and it takes a special type to do it well.
I think a lot of patients don't fully realize that when they're walking into an ER about what else might be happening, because they're focused on what's going on with their situation. So in addition to that, what do you wish that lay people or even other physicians really understood or grasped better about emergency medicine?
Goodness, that's a great question. What I would hope is that the patients using the ER and the physicians who need to lean on the ER realize that the ER docs that are running the department are the experts in triage. Their whole training has been focused on assessing live threats and stabilizing those threats. And, truly we're all tuned into the important elements of customer service. However, if the physician cannot be with you or with your loved one at any particular moment, I think the message is, please understand they are delayed or distracted by a very worthy cause. Every patient is equal, every patient's needs are important, but ER docs are charged with triage and stabilization of life, and if they're not there with you, they are practicing those skills for someone else. So please be understanding and patient is my request.
My wife had a gallbladder issue and found herself in the emergency room, and it was sort of towards the end of COVID, so it wasn't as bad, but COVID was still raging pretty well. And one of the things that struck her and struck me was how apologetic the nursing staff and ER staff was on, we're sorry we haven't been able to be in a while, we're sorry we're full. Sure. And her thinking, well, of course you're full. We're in the middle of the worst pandemic the country's seen since the Spanish flu. But it really struck me that they were cognizant of that and almost trying to apologize for it when they really shouldn't have been. And I know that there have to be patients who probably don't have the same understanding or are a little more demanding, but I think that's a great point, is understand that, this is not like a scheduled appointment to get your hair cut and you had to wait a few minutes. There's no way of knowing what that load's going to be in the ER at any one moment. And like you said, there could be 3 ambulances right in front of you and they're doing their best. So that's a great point.
Yep, everybody is doing their best. Throughout the ERs across this land, I am sure that the dedicated folks truly 24/7 are doing their best.
Dr. McHugh, I want to switch gears a little bit now because you're not in the ER anymore. You're working for Curi, and you've practiced for 21 years and then made that decision to become a managing director for Curi. And I want to know what drove you to make that decision.
There are really 2 things that I've developed over my career. One is an intense interest in medical malpractice, and the other is an intense desire to support and advocate for physicians. And the company that I'm privileged to work for now, Curi, is a full-service physician advisory firm which has earned its stars in aggressively and successfully defending physicians in situations where there was no bad medicine, but lawsuits ensued. And I want to qualify a couple of things. I speak as my own person. I don't speak on behalf of Curi. And also in any lawsuit, there are never any good circumstances. There's always somebody that's been harmed. But I have sensed over my career that in American medicine, a large proportion of the lawsuits are perhaps unnecessary. I'm not exactly saying frivolous, but they do bring a lot of pain and suffering to the physicians as well as to the injured patient or family that's undertook the lawsuits also. So it's really with those goals in mind that I saw this second career, or this back nine, if you will, in a place where I could serve my profession, help build community, and use my skills, experience, and passions for the benefit of others. And I feel very privileged to be here.
Let me ask about that for some of those malpractice suits. Do you see them more in one specialty or another? Do you see them more in emergency medicine versus obviously something like radiology? What do you see when you take a look at these? Understanding again, you're not speaking on behalf of Curi, but in your observation, what kind of specialty do you see getting the most of these lawsuits?
In general, and there are certain trends throughout medicine, but in general, the surgical or interventional specialties tend to be at higher risk for lawsuits. So, think the busy OBGYNs who are just delivering babies repeatedly throughout the night. Think of general or orthopedic or neurosurgeons who are doing high impact procedures for patients that, without their skill and intervention may not necessarily die, but have some ugly outcomes. Invasive cardiologists who are, bringing technologies now that 20 years ago we just didn't have to save life, to preserve life, to improve life. In general, the more intervention, the more risk, the more likely it is that a physician will be sued, and a bad outcome will be phrased as negligent rather than just an unfortunate outcome of illness.
I don't want to go too far down this path, but I do have a question. This is for both you, Dr. McHugh, and Ron. There's been talk among certain politicians about tort reform for this exact kind of thing for medical malpractice. What do you hope to see change, if anything, from a legal perspective?
Ron, I'll let you go first.
Yeah. So I think, first of all, Dr. McHugh made an interesting distinction, which is the difference between a bad outcome, an unfortunate outcome, and bad medicine. And unfortunately, there's an awful lot of unfortunate outcomes that happen where some plaintiff's attorney trying to hit a home run attaches that or tries to make that bad medicine. Those of us who have lived in North Carolina and who are in healthcare, understand the old stories of John Edwards making millions of dollars on lawsuits that were not that weren't bad medicine. There was an unfortunate outcome, and that's the part that bothers me. If somebody is injured through real bad medicine, and it happens, nowhere near as frequently as the number of lawsuits that happen, there's compensation that they should have, compensatory damages if a person can't work because of bad medicine, et cetera. I get that. And that's what malpractice insurance is all about. Just like if I injure somebody with my car and I was drunk at the time, my auto insurance can cover that. But that's different than a plaintiff's attorney being able to hit a home run for millions of dollars for something that isn't bad medicine. I hope that stuff gets curtailed. Personally, I would love to see, and I don't know Dr. McHugh's feeling on this, I would love to see malpractice cases tried before a jury of their peers, which would be a panel of physicians. I've been in healthcare for over 30 years. I don't feel qualified to sit on a jury to decide malpractice. I'm not clinical. So I'd love to see the awards be curtailed on the punitive side. And I'd love to see there be a different level of review on whether something truly was bad medicine. And to me, that would have to be other physicians. But that's just my own personal feeling.
Dr. McHugh?
I do feel that, I truly wish that the system, the medical legal system was set up to discern with higher accuracy, with higher reliability, the difference between a bad outcome and bad medicine. Because clearly in our world, with all the trauma, with all the substance abuse, with folks continuing to drink and smoke, there are going to be bad outcomes along the way when medical problems come up. But I think only a relatively small proportion of those arise from bad physicians.
Yep.
So it's a tough situation.
I want to switch gears a little bit and talk about an article that you wrote for the North Carolina Medical Society that was particularly good, I thought, talking about burnout. And we'll be linking it in the show notes if anyone listening wants to take a look at it. We're going to discuss it here now. And you wrote for the North Carolina Medical Society, citing a 1980 study, that there are 6 key drivers of physician burnout, and that's work overload, lack of control, insufficient reward, absence of fairness, conflicting values, and breakdown of community. Which of these, or which few of these, do you think does the most damage to physicians and damages the morale the most, and causes someone to want to get out of the practice of medicine?
Yeah, that's a really wonderful question. Again, I want to make sure that the listening audience understand, that original research was done by Dr. Christina Maslach. She has worked tirelessly and repeatedly to educate us all on this difficult problem. She does list those 6 factors, and I have to say that if I was asked to identify the most salient one, I think it really would be work overload. When I look back at the expectations that have been placed on physicians just simply over my career, the amount of things that have become relevant in medicine nowadays is really just escalated. And when I speak on this topic, I like to quote an article from 2022, which talked about just revisiting the time needed to provide adult primary care. And this was a very thoughtful paper that came from both Baltimore, Chicago, and Imperial College London. And essentially, the conclusion was, if a diligent family physician were to look after his panel of patients and adhere to all the suggested guidelines, he or she would need 14 hours for preventive care, 7 hours for chronic care, and over 2 hours for acute care, and then 3 hours for documentation and inbox. And as we all know, no physician has a 26.7-hour working day. And the work overload has been targeted as a grade driver, the overload that comes along with the electronic health record. And then I think a close second to that would be the lack of control. Unfortunately, medicine tends to be focused on the business and the dollar at the expense of the patient. And that's a fundamental disconnect for so many doctors, and they feel frustrated and demoralized as a result of that.
I was on a flight early this morning flying back into Raleigh, and as I settled into my chair and got ready to sleep, with the comfort in knowing that the pilots on the plane were well rested and qualified and et cetera, and control the plane, it sort of hit me. And I was thinking about this interview. I wonder how good I would feel if I sat there and I knew that half of all pilots reported being burnt out. I wonder how I would feel if I knew that the percentage of active pilots over the age of 55 was getting greater every year, which means we're not replacing them and going to run into a shortage. I'd wonder how I'd feel if less than half of pilots would recommend that profession to their children. And I wondered how I'd feel, and this gets to the work overload, if I knew that there wasn't a federal law that required that pilots could only fly so many hours at a time and so many hours in a week, And I bring those up because those are all things that are relevant in medicine. There's been recent studies that show that half of all physicians are reporting that they're burnt out. That the average age of physicians is getting older and older, meaning we're not replacing them. And that's going to create a shortage, that less than half of physicians now would recommend that profession for their children. And this gets to that workload. There is no federal law on how many hours a week you can work or how many hours in a row you can work. And I sat there and thought, man, if all of those things were present, A, I probably wouldn't have slept on the flight this morning. And B, I would imagine there would be some sort of national outrage on, what are we doing? And how are we letting these pilots fly when they're burnt out and tired and overloaded and don't feel like they're in control of their environment? But that's exactly, from my perspective, what's happening to the House of Medicine. And it struck me when you talked about that was probably the most salient one, because we don't allow it in so many other professions, but in a profession where, again, literally your life is in someone else's hands, we somehow do, and we consider it okay. And I think that's a real travesty myself.
I think it's a great question to ask, and I really do enjoy looking at the comparisons in business between, say, the FAA, the flying operations, medicine. There's lots of questions asked, if Disney or Toyota ran your hospital, would it be different? But we've seen just recently amongst air traffic controllers, because they've been overworked and because they've had to do extra shifts, that there's been a whole lot more near misses and 1 or 2 accidents. And I think, as you rightly say, Ron, the parallels between the professions are obvious.
Absolutely.
Let me ask you this, and it may be something you may or may not know the answer to, but in your experience, obviously understanding burnout has always been, and overwork has always been an issue for the modern practice of medicine. When do you think that burnout has really began to be a real problem in our American healthcare system, or overseas? What your observations from being overseas?
So it's a very, very good question. If there is one thing I welcome about the pandemic, it is the fact that the presence of the pandemic has normalized and legitimized healthcare providers' pleas for some change. So to answer your question, the initial work that was done on burnout was in the 80s by a Dr. Freudenberger, who was up in New York in a pediatric clinic and identified things about his colleagues and, more importantly, himself, and realized that these were caring physicians, caring providers that were overworked. And it's taken about 40 to 50 years to get to the point where in 2022, the U.S. Surgeon General actually wrote from the White House and in the New England Journal of Medicine that this is basically an existential threat to ongoing service provision. and it's a threat to our overall country. So it's taken a while, but I'm relieved now that through the AMA and through other leaders, there are knowledgeable folks saying that burnout's not the result of a deficiency in resiliency among physicians, but it's due to the systems in which physicians work. And that's Dr. Sinsky, who's the Vice President of Professional Satisfaction at the AMA.
Yeah, I was at a meeting with a bunch of radiologists last weekend, and there was somebody presenting on radiology burnout. They had some great data on, what happens with failures and diagnosis after they've read too many studies, et cetera. And he drew the analogy of saying, he said, if you look back, he said, really, we started to understand the impact of combat on troops after Vietnam. We didn't really call it PTSD, but we sort of got it. We didn't do much about it until we had, Iraq and Afghanistan, et cetera. And now we understand, PTSD, and we're trying to make efforts to address it. And he sort of drew the same parallel. He said, if COVID did anything positive, maybe it's shining a light on an issue that was always there, which, as you pointed out, which is burnout. And now we need to learn how to deal with it better and how to put systems in place and supports in place to address it. But at least it's now something that can be talked about, much like, soldiers coming back from Iraq or Afghanistan and talking about PTSD and us having a better understanding of it. So it's, I thought that parallel was interesting, that it's been around, as you pointed out, for a long time. Now we got to figure out how to address it and deal with it. Because I get nervous about if we can't address it and deal with it, if we can't turn back some of these trends, the next pandemic, we could get caught with our proverbial shorts around our ankles, and that's not going to be fun.
Mm-hmm.
You wrote in your article for the North Carolina Medical Society about some responses to burnout, and I want to touch on a few of them. You talk about creating an environment where clinicians feel safe to admit they feel broken. What does that environment look like, and what kind of tools do physicians and do hospitals need for that?
I think it's an environment that looks distinctly different from the House of Medicine 20 years ago, when physicians felt for some erroneous reason that they needed to wear superwoman capes and that they had the answers to everything. And nowadays I'm actually thrilled by perhaps a more sensible or sensitive younger generation of physicians that say, we don't subscribe to that idea. We cannot be all things to all comers. There's that phrase that I think says you cannot pour from an empty vase or an empty pitcher. And, you have to make sure that your own tank is full. Again, the flying analogy is you put your own oxygen mask on when the plane is going down before you attend to the needs of children around you. So I'm pleased that there's the start of a culture change within the House of Medicine, which very much starts at home. Like politics, all burnout is local. And, I admire some physician groups where their key leaders or their executives are saying, okay, we've got physicians that identify as being in trouble. The flame of burnout is singeing them heavily. And just having that discussion and being open to say, these are my needs and I need our system to change to help me. That's really step one, which is the commencement of a local change in culture.
Which groups specifically, if you don't mind my asking, do you think are doing a particularly good job with this right now?
Well, fortunately, my own specialty, emergency medicine, probably one of the highest frequency for burnout. The lead specialty society, American College of Emergency Physicians, is very forward-thinking and progressive on this. I'm also impressed by work that comes out of the orthopedic surgeons' houses, the cardiologists. Lots of people, especially intensive care doctors, these high acuity environments, they've realized that if they don't take charge of this, it's going to be all-consuming.
And you think that, you mentioned, younger physicians coming in realizing that this isn't what they want to subscribe to, and that was kind of your second point that you had on there, was being the change you want to see. Does that mean making different employment demands when a physician's going to go work at a hospital or if they're in surgery, if they're going to go work at a surgery center? What does that look like in practice?
I think it really, the way I see it most successfully is younger physicians standing up for themselves and saying, look, if you're going to ask so much of us, you need to put some constraints on our availability time. Just basically saying we're not superhuman. We're human. We're subject to weaknesses and failures that everybody else in America says, yes, that's okay. We need to allow you to sleep. We need to allow you adequate time off. And to go back to Ron's example, pilots are the prime example. So I don't think physicians are asking for anything special. I don't think they're asking for any, particular special treatment. Just that some same principles be applied to those folks that work with machinery in a factory, or those folks that fly planes.
One of the things you wrote too, that as a not a clinician, I had wanted to ask you about, just because I'm not sure what it is. You said familiarize yourself with the NCPHP. What is the PHP and how can that help?
The North Carolina Professionals Health Plan is an absolute blessing for the 40,000 or so healthcare providers that are licensed by the North Carolina Medical Board. Essentially, the PHP is an organization that will work with providers who, have ended up in great distress. The addiction rates in medicine and in law and in pharmacy and veterinary sciences are incredibly high. And fortunately, there is a body of dedicated professional servants in the PHP that physicians can reach out to. Unfortunately, in years past, they've perhaps gotten themselves a bad name because they've been seen in a punitive environment. They've been seen as the remediation that bad doctors get sent to. But truly, whilst they do perform that function of monitoring physicians in recovery, they also perform a very admirable function of supporting physicians that self-identify with burnout and will go there at an early stage before a patient is harmed by a bad outcome. And I just continue to applaud the work that Dr. Jordan and all his colleagues do.
I want to backtrack a little bit because, Ron, I think you've got some statistics on this because we've talked a lot about what are some of the causes of burnout. We talked about overwork. We've talked about the culture in some of these in our healthcare system, and we talked a little bit about what some of these responses could be. One of the things that I don't think necessarily patients realize is how this might affect all of us in the near future, particularly with the physician shortage. So, Ron, I'll flip it over to you. What is burnout doing to the pending physician shortage?
Well, there's been a lot of work and a lot of discussion done on the physician shortage, and one of the things we know is, and some of the work is done around looking at the percentage of practicing physicians that are 55 or older. And the reason I look at that is you could think, okay, most of those physicians are probably going to retire in the next 10 years. And given the fact that becoming a physician is more than a 6-week training course, and takes, 10, 14 years, depending on specialty, et cetera, to train a physician. In other words, the people who are going to replace those folks who are retiring better already be in the training programs. If they're not in the pipeline, they're not going to get here fast enough. And so you can compare the pipeline, if you will, with the folks of that are in that sort of age bracket. And what we see is a significant percentage of the practicing physicians are over age 55 and more than what are in training. That's one concern. The other is we see that those percentages that are over age 55 are ticking up almost across the board. That means we're not, and haven't been for a while, replacing them with sort of the next wave. Emergency medicine, which by nature, because of the stress and the working nights, et cetera, that puts on it, tends to be a bit younger of a specialty, a younger man's game, if you will, than some of the other specialties. For example, radiology. 56% of all practicing radiologists are over age 55. Only 37% of all practicing emergency medicine physicians are over age 55. But that number was only 34% 2 years ago. And so it's ticking up. And what we know is there aren't enough people in the training program right now to fill the departure that's going to happen over the next 10 years. We also hear stories about training programs not being able to fill all their slots. For the first time in my understanding of healthcare, and that's reflective of people just don't want to go into medicine as much anymore because of some of the demands. So, that's what tells me I get worried about what happens if the next COVID 10 years from now, if we just don't have the people to staff it, if we don't have those heroes. The other thing, and since I'm the economist on the call, I need to bring it in. Part of the fix of this is we've got to stop sending the message to physicians that they don't have value or worth monetarily. And I'm talking primarily about Medicare and the federal government on that, although the payers are guilty of that as well. The amount of money per unit of service that Medicare pays today is 11% less than they paid 24 years ago. The Medicare conversion factor in the last 24 years has gone down by 11%. It got cut again this year by over 3%. And so if you're beating your head against the wall and you're putting in these long hours in an ER, and the message you get from the federal government is you're worth less today than you were yesterday and less than you were 24 years ago, that has to have impact. And I think it's also driving up, for some physicians, the number of hours they're working to try to maintain an income level in a dropping reimbursement. Just by point of reference, over that same 24 years, the cumulative general inflation over that 24 years is 82%. The median price of a home is up 260%. But we're telling physicians that you should make less money this year than you did last year, and less money than last year than you did the year before, and less money than you did 20 years ago. And again, I most of the physicians I meet didn't go into medicine to make money. It wasn't a financial, it was to help people. But I just don't know how you continue to want to do it with that same vigor when every year somebody in the government's telling you you're worth less. That to me is a part of a problem.
Dr. McHugh, do you have any observations or thoughts?
I certainly would agree with most of that. I agree wholeheartedly with the sentiment that Ron espoused, which is, the vast majority of physicians do not go into medicine to make money. They go in with very, very high ideals of community service, serving individuals. And, in my current work dealing with Curi's owners, I see this repeatedly week after week. And, my member owners say, I never went into this to get rich. I just went in to do my best for other people. But the collective demoralization that ensues from, showing up and putting your own life at risk through COVID, and then, your federal government awarding you with a pay cut after that, I think that, together with all the extra costs of pulling in experts to help protect, optimize, and grow your practice through challenging times, that basically means that the majority of physicians are working much harder, but their take-home pay is less. And of course, their bills are going up with inflation. And it's just the frustration that so many are saying, especially over the age 55, I'm not going to do this anymore. Self-protection is most important. And just to share with you some helpful data, the American Association of Medical Colleges did a much publicized report in 2018, and their postulate is by 2033, depending on the slope of the curve, will be deficient somewhere between 54,000 and 139,000 physicians, and that's got obvious implications for service provision.
On that note, I want to switch to something probably a little bit more hopeful now, as we're wrapping up our interview today, Dr. McHugh. And the first one is you mentioned COVID-19 as having a silver lining of bringing some of these issues to light. Are there any other signs of hope for a change in our culture for our healthcare system?
What I take as a sign of hope is this ongoing discussion about the needs of the healthcare provider community. I think that now enough people have heard this, and it's coming from enough expert academic and business sources that people are actually waking up and saying, wow, this is real and this has got immediate effects. The Commonwealth Fund published an international study in 2022, and they actually positioned America as being somewhere in the middle of burnout when compared with 10 other civilized countries. But what I took to be reassuring was their conclusion was, quote, our analysis demonstrates that now is the time for immediate action, end quote. And, you know, if enough experts and leaders such as the Surgeon General, the National Academy of Medicine, sharing these ideas, then I'm hopeful for change given the innovative nature of my physician colleagues and the ingenuity and resilience that they have. So I am hopeful.
And finally, you know, I want to ask what your message is to aspiring, particularly emergency medicine physicians or those interested in emergency medicine who are perhaps a bit hesitant right now because of the mental health outlook of many of the other emergency medicine physicians that are out there. What would you say to someone who's interested in becoming an ER doc?
My personal message would be that the work that you do is some of the greatest work for humanity in this country, and the privilege of coming alongside another human at their gravest time of need, to relieve anxiety, to, you know, reduce pain, and to use your skills and personality and training to help guide them on a care plan for that day. That's the greatest privilege. I looked after many Wall Street bankers, and I would always ask them once they were stable, you know, what do you do after you've earned $50 million in the morning? And the more perceptive of them would say, you know, I look to give back. And a career in medicine is a career where daily you're allowed the privilege to give back. But it comes with a price, as we talked about. And I'm hopeful that if physicians will position their needs first so that they can look after themselves and then allow them to look after their patients, I'm hoping that our wonderful medical care system will continue.
Well, Dr. McHugh, I want to thank you very much for sitting down with me and Ron today on the FLATLINING Podcast and having this discussion. It's needed. I think by having this discussion, we're doing exactly what we talked about, which is bringing it a little bit more to light and having more people give it some thought. So thank you.
Yeah, it's my pleasure, and I'm grateful for both of you.